Good afternoon, everyone. Welcome to our weekly multidisciplinary endocrine grand rounds. We are very happy today to have Dr. Mahsa Javid talk to us. Dr. Javid joined University of Louisville just under a year ago in October of 2022. She is an associate professor of surgery, endo chair in endocrine surgery at University of Louisville, and also the associate program director for the surgery residency program. She trained, went to medical school at Cambridge, London, or Cambridge, and did her training and obtained her PhD, the D.Phil, which is equivalent to the PhD at the Biomedical and Clinical Sciences at Trinity College at Oxford. She trained in surgery in the UK before moving to the United States. She did endocrine surgery fellowship at Yale, and then was for a brief time at MUSC before she came to Louisville. She has extensive surgical experience and also has been involved in a number of clinical studies and has a long list of fellowships and grants that she has had in various aspects of endocrine surgery. Her special interest has been in thyroid cancer, and she now has a grant looking at advanced glycation end products in thyroid cancer. And today she will be talking to us about reaching the mark in thyroid cancer. Dr. Javid.
Very good. Well, thank you so much for that gracious introduction and the invitation to share this time with you. It's an honor to be here and talk to you about some studies in thyroid cancer. Now, reaching the mark in thyroid cancer is about how do we target thyroid cancer and really get to the molecular treatment of it. So it's a bit beyond the surgical aspect, and I think actually my audience today is more of an expert than I am at this. So please feel free to interrupt or ask questions, whether you're online or here, and we'll be able to make time for that at the end as well. But it's more a conversation, and you'll probably know more about a lot of this than I will. So I just wanted to start with a story. Why do we need to target thyroid cancer at all? And I think the biggest story is looking at the extreme end of things, which is anaplastic thyroid cancer, which is probably one of the worst cancers you can have, with a median survival of 6 months or less, that usually ends in fairly horrific ways, considering that the tumor completely surrounds the trachea. It can invade local structures, the esophagus, bone, the carotid sheaths, and it's often metastatic at diagnosis, such as here with lung metastases or brain metastases, bone metastases, pretty much everything you can think of. These are almost unresectable cancers, although in the occasional time that we can get them out, we can give additional treatments. But we need better treatments, don't we? We need better treatments for this. Anaplastic, is thought to come from differentiated thyroid cancers. So it's not just out of the blue that we get these. So treating all thyroid cancer is probably a good idea. For the most common cancers we see, by far the most common are the differentiated thyroid cancers. And for a long time, we had a kind of coherent story about how to manage these, which has changed over the last decade or so. the extent of treatment, especially surgical treatment, is mainly based on whether the cancer is spread or not into the lymph node basins, whether that's the central neck, which is marked as number 6, the central neck, or whether it's gone to lymph nodes in the lateral neck, which are marked from zones 2 through to 5 in the lateral neck. And really, it was simple. We had a gold standard. We would take the whole thyroid out. We would do a central neck dissection, meaning remove all the fibrofatty tissue in this zone 6, maybe zone 7 under the sternum, and there you had it, you know, whether or not there were lymph nodes involved. And then probably you'd get some radioactive iodine treatment afterwards as well. The reason radioactive iodine treatment was given, it was one of the first targeted treatments around. It's been around since the 1940s. It was probably one of those, you know, magic keys to treating cancer when we first came across it. It's, you know, the radioactive iodine I-131 is taken up by the sodium iodide transporter, just as is just normal iodine, and so it just treats the, you know, remaining thyroid cells that are around. However, in a patient like this who's got extensive disease, multiple lung metastases, you know, you can probably guess that this is a patient who is radioiodine refractory, and that is an issue for actually up to maybe 10-20% of cases where we get recurrence after radioactive iodine treatment, and in those who advance to having distal metastases. Now, radioiodine refractory disease accounts for most of the deaths in differentiated thyroid cancer. So we can see that it does affect overall survival. So it's not just an indolent disease, these are common enough to warrant further investigation and treatment trying to manage these tumors. So this is an example of a well-differentiated thyroid cancer that has spread to lymph nodes. These are right and left central neck lymph nodes that you can see on ultrasound here. I hope this laser isn't too distracting. Let me know if you want me to change it. But these are ultrasound of the central neck. So the trachea is midline, the carotid is lateral, and then everything in between that you can see lesions on, which I've marked out, have got are abnormal lymph nodes. So they can be rounded, elongated, without a hilum, and that looks abnormal on an ultrasound. And so, you know, lymph node recurrence is associated. Lymph nodes are associated with a recurrent disease after surgery in differentiated thyroid cancer, and they are related to distant metastases and cancer-specific deaths as well. So just looking at the scope of this, let's look at the overall picture. A lot of people have thyroid nodules. In fact, up to maybe 50%, half the population, maybe more if you looking at neck ultrasounds. We get a lot of those for other causes, such as, you know, someone who's been in a motor vehicle accident gets a scan, and we find that almost 2/3 of people actually have thyroid disease, and these are in the iodine sufficient areas, let alone those who are deficient. However, so that's a lot of nodules. However, only 10 to 15% are actually malignant. So how do we pick at those? But even if we know how to find the malignant disease, we know that this is such a huge, vast amount of people who are going to have tumors. And then we have to differentiate those who are going to be more indolent in behavior with those cancers that are actually going to go to the lymph nodes, metastasize, and recur. So how do we think about reaching the mark in thyroid cancer? Well, I guess we have to go to the molecular level and specifically look at mutations and gene rearrangements. And so this is some the well-known pathways that lead to that have mutations that lead to thyroid cancer. The rearrangements and mutations that are related to papillary thyroid cancer are highlighted in blue. Those related to follicular carcinoma are related in red. And there's very little overlap, in fact, but from the table to the right, you can see what used to be the most common mutations around, and then I've added several that have been added to that since. But anyway, there were mainly two pathways: the MAP kinase pathway, you can see on the left, and then the phosphatidyl inositol 3K pathway here on the right, which ends up in mTOR. At the cell membrane level are the receptor tyrosine kinases. This will become important for some of the molecular targeting agents that have been mostly studied and used in thyroid cancer. These are important because once a ligand is attached to its receptor, this signals into the cytoplasm these pathways that lead to nuclear sensing and changes that will essentially lead to cell proliferation, division, and when there are mutations in these pathways, it leads to cancer formation. So along this line are the RET PTC rearrangements. RAS, BRAF, MEK, and ERK go down the MAP kinase pathway, and then PI3K and AKT-mTOR and the other one. P10 is a potent inhibitor of this PI3K pathway. So these are things we're going to look at in a little bit more detail when we're talking about reaching the mark. BRAF, as you can see from the table, is probably the most common mutation that occurs in differentiated thyroid cancer. Here it says about 45%. Some people say up to 50, 60%, and we can see that in a bit more detail in the summary of the cancer genome atlas mutations that occur in thyroid cancer. So the majority of the differentiated thyroid cancers had BRAF, mainly V600E mutations, you can see from the bottom graph. And it's interesting that the mutations are basically mutually exclusive, whether you have a BRAF-like mutation or a RAS-like mutation. Remember, they were on the same pathway. They are mutually exclusive. You don't get mutations in both, but you get them in one or the other, and that single mutation is enough to lead to a change or activation of that oncogenic pathway that eventually leads to cell signaling changes and proliferation, lack of checkpoint inhibition, and eventual cancer formation. So there are some variations of the RAS mutations: NRAS, HRAS, KRAS. The EIF1AX mutation is a newer one that has been looked at, as is TERT. And then we have the RET PTC fusion or rearrangements that are in a category of their own. So these are the targets we mainly talk about with current knowledge and the current studies. So the sodium iodide symporter is what I referred to, which has been known for decades. This was one of the prime initial targeting factors that has been known in any cancer treatment at all. And we give radioactive iodine to pretty much anyone we think is going, is needing it, meaning currently the more advanced differentiated thyroid cancers, anyone that required a total thyroidectomy, maybe with lymph node dissection, maybe with certain characteristics of their pathology subtype, some of the more aggressive subtypes such as tall cell variants, whether there's extrathyroidal extension, how many lymph nodes were involved, whether there was any local invasion, etc. So it's a bit more of a prolonged discussion now, as you're aware, than, oh, we're just going to give it to everybody. But we still give it to a fair number of patients with differentiated thyroid cancer. Now, unfortunately, as we said, maybe 20% will still advance. And so these are the categories that we're going to look at in terms of what other targets can we reach. And those tyrosine kinases are the most common inhibitors that we'll use. But I'm sure you've all memorized this table. It's the recent clinical trials that have used targeted therapies in thyroid cancer over the last decade or two. the numbers treated are not fantastic for most. There's a lot of ifs, ands, or buts. There's a lot of different median progression-free and overall free survival time. So we'll look at these in a bit more detail. So first of all, let's look at the most common pathway, the MAPK, or the mitogen-activated protein kinase pathway. That was the one that you found on the left of the drawing. So any one of these major players in this pathway can be targeted. The importance of this pathway is that it connects this extracellular signaling to the nucleus, and it activates proliferation, division, apoptosis. So any mutations in this pathway will lead, to problems in those factors leading to cancer. So the BRAF V600E inhibitors, this is the most common mutation, we said, in differentiated thyroid cancer. So this has been a well-studied inhibitor in thyroid cancer, and we've got a couple of competitive inhibitors here. Of course, I'm not going to say them very well. That's all then you can. Vemurafenib and dabrafenib have been used in clinical trials, mainly for recurrent and metastatic papillary thyroid cancers, or in the case of dabrafenib, in metastatic unresectable papillary thyroid cancer. Here, the progression-free survival, 18 months. However, 2/3 of patients had grade 3 and 4 adverse events, and they were pretty severe. When you get to grade 3 and 4, they included things like having a stroke. However, these have been approved for ATC, in fact, because that is a common mutation that occurs as well in anaplastic thyroid cancer. There is the most useful area where these inhibitors work is actually by trying to re-engage the sodium iodide transporter. Essentially, BRAF mutation inhibits or reduces the sodium iodide symporter. So therefore, the patient becomes refractory to RAI treatment. Now, these inhibitors have been shown to increase RAI uptake, and a percentage of patients actually become actively able to take up the radioactive iodine. And in this case, it was up to 60% had new radioactive iodine. Now, that is variable for all the MAP kinase pathway targeted agents. And in some cases, it was shown in some clinical trials that there was quite a lot of patients, a large percentage have increased RAI uptake, and then in follow-up trials, it didn't turn out to be so many. So let's look at the MEK inhibitor again. This is the MAP kinase, essentially this whole pathway inhibitor, selumetinib. Again, in phase 2 trials, this was used for advanced differentiated thyroid cancer, had fairly long median progression-free survival. Interestingly, those with a BRAF mutation had a longer survival than those with wild type. Maybe you'd expect that. But if you did have a mutation, this drug was more effective in those who had an NRAS mutation versus a BRAF mutation. Again, it increased RAI uptake. Essentially, it caused redifferentiation. So once you've got more and more mutations in these pathways, you become less differentiated. You're on your way to anaplastic thyroid cancer. Now, these drugs are trying to inhibit those mutations from working and therefore redifferentiate the cells, which can lead to increased symporter activity and increased RAI uptake, which is very useful. So again, some of these drugs are used in combination with RAI for more effect. So why not do combination therapy, even though you may have only one mutation in this pathway? If we target 2 areas, you might have a better effect. And this was definitely found in this very great breakthrough combination therapy for dabrafenib, BRAF inhibitor and MEK inhibitor, trametinib. This had been used for melanoma. I think this is where a multi-institutional clinical trial got its idea to use it for anaplastic thyroid cancer. And this was, as I said, a major breakthrough for ATC, which has basically had no effective treatments, whether surgical, chemotherapy, radiation, or anything. And here we had over 65% overall response rate, which was amazing. It had to be discontinued in a large number. You can imagine a lot of those would have been from progress of the disease as well as side effects. So another combination has been this MEK inhibitor, trametinib, with a VEGF receptor tyrosine kinase inhibitor, and that's been used for differentiated thyroid cancer, but it hasn't proved to be that effective in follow-up trials, and so I don't think it's been used that often. So let's look at this right arm pathway, phosphatidylinositol pathway that includes mTOR. The importance of this pathway, again, the alterations lead to increased angiogenesis, very important for tumor growth. It leads to drug resistance, cancer progression, and metastasis. Again, all this to do with cell proliferation, apoptosis. So everolimus was initially thought to be a great drug. It's an mTOR inhibitor. It was used in phase 2 clinical trials for advanced thyroid cancers, but it only had modest anti-tumor activity and lots of fairly severe side effects. So it's not been generally used in advanced thyroid cancer treatments. However, looking further at anti-angiogenic factors, there are multi-kinase inhibitors that target multiple targets, including BRAF, but also RET and VEGF, which is very important for angiogenesis. BRAF is important for angiogenesis as well. So these are tyrosine kinase inhibitors that, basically target a variety of these proteins, and sorafenib is one of them. You've probably heard of the Decision trial that was completed in advanced differentiated thyroid cancer, and it's been FDA approved for that treatment because it had almost a doubling of progression-free survival time with significance. Response rate was over 12% versus less than 1% in placebo. However, there was no difference in overall survival. However, there was a large crossover between the arms. There are a lot of grade 3 and 4 adverse effects, 1 death, but generally overall, it was approved and thought to be, a good treatment. There is another one, lenvatinib, and this one has also been FDA approved. It was looked at in the SELECT trial. It actually targets fewer points than the sorafenib, but interestingly, it had more deaths, more adverse effects, even though it had higher response rates as well. So I'd love to hear your opinion about which one you would prefer to use if it came to advanced thyroid cancer. Since we're talking about angiogenesis, I thought I'd give you a little brief story about one of the projects I have been working on at my last institution and hope to continue here. And that's looking at an angiogenic factor called SFRP2. This had been looked at by my colleague in surgical oncology, Nancy DeMoore, who's also a breast surgeon. And she'd looked at this while she was at University of North Carolina, and found it to be an interesting factor. It's secreted frizzled related protein 2. It's been shown to be associated with poorer outcomes in several malignancies, including breast cancer, sarcomas, and others. So it's not been really looked at in thyroid cancer. And so I decided to see if we could see whether there was any association between increased SFRP2 and the advanced thyroid cancers. So we did some studies to look at the differential expression of this angiogenic factor in PTC and comparing it to normal thyroids. We looked at normal thyroid tissue from patients without cancer, as well as normal tissue adjacent to cancer. Okay, so two separate control groups there. And we also looked at it in two different cell lines, a classic variant for PTC and a follicular variant. And we used an antibody, which my colleague had also produced, to the SFRP2 to see if we could reduce any cancer growth or characteristics. So first we did some immunohistochemistry, and we stained lots of core thyroid cancer paired samples with different stages of thyroid cancer and looked at the uptake in the variety of cancers compared to normal thyroids. We did a analysis using ImageJ and then came up with a way to score how intense the uptake of staining was and how frequent. And then we also did in vitro experiments using the two different cell lines, and we mainly looked at proliferation and apoptosis, and we analyzed it. So should be able to look at some results. So with respect to our immunohistochemistry, you can see up here, this is an adenoma. This is a normal thyroid follicle. Okay, so the follicular cells are surrounding the colloid. This is just a benign adenoma, normal adjacent tissue. Okay, so this is normal tissue with that is surrounding a cancer, and then this is just normal thyroid cells with no tissue at all. So I think I might have missed a slide. And we also looked at PTC. So you can see a lot, the brown staining is positive for SFRP2, and it was much higher in the cancer group compared to adenoma or normal. And this was quantitatively true significantly, so comparing papillary thyroid cancer with either adenoma or normal. Yes, exactly. Yeah, so this you can see the typical kind of papillary pattern for PTC, and pretty much all the thyroid cancer cells are staining for SFRP2, whereas in adenoma and normal, there's hardly any staining. We didn't see any change in SFRP2 expression according to the stage of cancer, but I think that's because we just had so much staining overall, whether it was stage 1 or 4. So that's something we could look at maybe in a bit more detail. Say that again, sorry. So we only did those, that was for our cells, not in the immunohistochemistry, so I'll come to that. But overall, staining at the protein level higher in cancer versus normal, and then the next slide was then going on to look at adenoma versus normal adjacent tissue in patients who had thyroid cancer, but normal tissue about at least 1.5 centimeters away. So we were trying to see if there's a field effect of sorts, if there's some sort of epigenetics that's going on, not directly a result of a mutation within the tumor cluster, but is there a non-genetic effect outside of the tumor that will eventually change that area to a cancer? And we did find that the expression of SFRP2 was higher in normal adjacent tissue in patients with cancer than just normal tissue in patients who did not have cancer. It was also higher in adenoma versus normal as well. But no significant difference between adenoma and the normal adjacent. So, you know, whatever that means, right? So here we are now looking at the cells. So we're looking at the classical variant and the follicular variant cells. And first of all, we looked at proliferation. There were no changes in the proliferation rates when we treated these cells with the monoclonal antibody to SFRP2. This was not surprising because in the other studies done on other cancers, there didn't seem to be a proliferation response. So if it's not proliferation, it's got to be apoptosis, right? So we looked at apoptosis next, and as well as necrosis. And here we had the two different cell lines again, the classic variant and the follicular variant. And we did find that there was a significant higher rate of apoptosis when we treated these cells with monoclonal antibody to the SFRP2 versus two different controls. One was just a normal antibody IgG without the SFRP2 antibody, and one was just PBS as a vehicle. So we found this difference to be true in both the cell types. It seems to be a little bit higher, in fact, in the follicular variant for some reason, and that seemed to be consistent over multiple studies. There was no difference in necrosis in the either cell type. So it really is targeting apoptosis in this situation. So in conclusion, we thought that SFRP2 is higher, has higher expression in papillary thyroid cancer than benign or normal tissue. There is a difference in expression between the adjacent tissue to cancer than just normal tissue elsewhere. And again, this may underlie some sort of epigenetic factor going on with tumor formation. And that treating the cells with the antibody to SFRP2 can change the apoptotic rates. So there is further studies that we need to do to look into whether SFRP2 is, has different expression depending on the clinical aggression of the PTC. We need to look more into the normal adjacent tissue and see what, if any, is going on in that pathway there. So back to targeting. From that brief reprieve there. So immunotherapy is an area that's been looked at increasingly, especially in this institution, in looking at solid tumors. And the reason is that a lot of aggressive tumors have immuno-rich environments. They have macrophages, tumor-associated macrophages at that. These promote tumor growth. They actually make up a lot of the tumor volume. They take part in dedifferentiation. So going along that PTC may be poorly differentiated, going to anaplastic route as well. Now, it seems that the immune system is actually helpful to control tumors. So if there's a way that tumors can evade the immune response, then they're more likely to grow, right? So an important factor in the immune response are the cytotoxic T cells. So these are implicated in thyroid cancer because once they have a reduced amount, then and there's inhibition of this T cell activation, you evade the immune response, therefore you're not controlling the growth of the cancer, and they go on to become advanced, recurrent, or metastatic. So a couple of the molecules involved here are programmed cell death protein 1, PD1, or the ligand programmed death ligand 1, PDL1. Higher levels have been shown to be present of these molecules in the BRAF mutated tumors than BRAF wild type, and they have been associated with poorer prognosis as well. So what is immunotherapy? They are basically the antibodies to these molecules, so anti-PD1 or anti-PDL1. And pembrolizumab is the anti-PD1 antibody. It's been used in clinical trials in metastatic differentiated thyroid cancer and had a progression-free survival of 12 months in 36% rate. So, it's been thought to be something that we really should work on more. More recently and more commonly, it's been used with a combination. So whether you use an anti-PDL1 or PD1 antibody with a combination of the BRAF inhibitor essentially has been used I think in clinical trials as well, but also in preclinical models, especially of ATC, where it's been, really found to make a difference. And the preclinical models show great reduction in tumor growth, as well as, increasing that immune response that's required to control the tumor. So it's possible that a combination therapy will be required to target the tumor cells, as well as try and improve that host anti-tumor immunity. So just trying to close the circle, we come back to another patient who I saw a couple of years ago with a rapidly growing mass. This looks a little bit like the one we saw on my first slide. So it's sort of a tumor that's wrapping around the trachea. It's almost invading, but not quite, the esophagus. You can see a plane around it. That's CT and ultrasound. It looks bad. If you see something like this, it's bad. It's markedly hypoechoic, got calcifications, it's large, it's pushing structures out of the way, and there are lymph node metastases in the lateral neck. So the history gives it away. This was a rapidly growing mass. Unfortunately, they did not get a clear FNA prior to it being sent to me, so I repeated it, and we got diagnosis of anaplastic thyroid cancer, interestingly, on FNA, where you don't always get that result. Distant mets were ruled out because in those situations we don't operate, but since I'm a surgeon, I wanted to show you some gruesome pictures. Look away if you're sensitive. So this is an open neck. It's not my usual minimally invasive resection here, but more maximally invasive neck dissection. So this is both a central neck and a lateral neck incision where the skin and muscle has been basically pulled away. So there's not much. I mean, I can't even show you what this is. There's a mass, there's a tumor. You can almost not tell the different structures apart, and you might think, why on earth would anyone do this? But I tried, and we actually started to get some traction, and we started to be able to get tumor. You can actually see part of the tumor here, part of it here now. With the trachea here, this is the midline. So the head is up here. This is the chest. This is the midline. This is the lateral edge. So between the trach and this edge, all this is basically cancer, anaplastic cancer. Very difficult to get off, especially in one piece, and we actually had to get into the tumor to be able to even try and resect it. So more of the central neck here, tumor still present. You can see that we're seeing a little bit of the carotid sheath. This is probably the IJ, internal jugular vein. This is the sternocleidomastoid, which we managed to get off it, at least partly. I think there was some tumor stuck to that as well. And then as we advance, we're really getting into it now. We've managed to clear most of the trachea off tumor. There's this whole section, though, is remaining. We've managed to get some loops here, some strings around this internal jugular vein, which is important because if we get into that with this in the way, we can't control bleeding. That can be quite catastrophic. So it's important to be able to control these things and make sure that we can do it in a safe way. Otherwise, we'd just call it unresectable, call it a day, look for some targeted treatment that weren't going to work. So here we are trying to resect this off, and these are lymph nodes. These are lymph nodes. These are lymph nodes. So it's all in the lateral neck here. We managed to get some of these lymph nodes a bit further up now. Here's some tumor. All of this is going to be resected with the internal jugular vein underneath. And eventually we can actually show that I kind of pulled it away from sort of that posterior edge, moving it over, and gradually we can get this whole mass of lymph nodes off the internal jugular vein. We can, in fact, tie this off if we need to. In this case, I don't think we needed to in the end. We probably just came across it right here. And there was several instances of, the lymph nodes being stuck at that level. Now you can actually see the carotid artery. We couldn't see that up to now. So you've got the IJ, we've got the carotid, we've got some more lymph nodes, and eventually we get those off. So finally, we can see this is completely resected. There's a lot of nerves, a lot of vessels. All of these can be injured. So the trachea, the esophagus, the carotid artery, the internal jugular vein, the sternocleidomastoid is pulled away. With a lot of nerves, vagus, recurrent laryngeal is gone here, but the vagus remained. There's important sympathetic chain behind the carotid. There's spinal accessory nerve here that supplies the shoulder. There's the phrenic around here, and then there's, lymphatics as well. So there's quite a lot that could possibly go wrong, but in this case, we managed to get it all out. And I do my obligatory drawing just to show myself and the patient what we did. And even though we had to get rid of the recurrent laryngeal nerve on one side, in this sort of situation, you have to risk going to the other side. Bilateral injury is dangerous for the airway, but in this situation, if we're going to have any hope of being able to improve his situation, then we'd have to get the other side out, which I managed to do while preserving that recurrent nerve. I don't know how, but we managed to preserve some parathyroids, and we removed all these lymph nodes as well as the tumor mass. And essentially, I thought what was an R0 resection, meaning we removed everything visible and microscopic. Turned out the pathology showed a 6.7 centimeter ATC. All 31 lymph nodes were positive. We did sequencing on the tumor, and there was no BRAF mutation in this case. However, there was over 50% PD-L1 expression. Again, something that correlates to poorer prognosis. The usual combination of adjuvant treatment was given, which is chemoradiation, in this case paclitaxel with carboplatin, alongside local radiation, and this is trying to prevent recurrence. It is highly, prone to recurrence. And he did receive 7 cycles. However, looking at PET scans following that 7th cycle, we can see that there was recurrence in the neck, there was mets in the mediastinum, we're seeing it in the liver, so just all over. There's probably bone here as well. So diffuse metastatic disease. Unfortunately, neck recurrence was high. It was right around the larynx. That can easily lead to airway obstruction, so he underwent a prophylactic tracheostomy. However, there was this option that we're seeing now to use immunotherapy, a PD-1 inhibitor, in this case pembrolizumab, together with the kinase inhibitor lenvatinib. So this was used, it was started, he had 1 cycle of that essentially, but unfortunately had other complications, probably related to having a tracheostomy, and got pneumonia and unfortunately passed away. So we didn't see a long-term effect or any effect from that treatment. But it does beg the question, what should we do in terms of when do we give this and how and who to? So I expect you to all memorize this now. This is the takeaway message. I'm kidding. But we recognize that these are all the different targeted treatments that we can possibly see in thyroid cancer at the moment. We've got the 2 main pathways we talked about, MAP kinase and the mTOR. We looked at the angiogenic factors like VEGF. We've talked about RET, the mutations here, rearrangements in RET-PTC. We've got the immunotherapy, PD-1 and PD-L1, its ligand. There are some others as well, and we talked about some of these other tyrosine kinase inhibitors, as well as our favorite sodium iodide transporter. So there's just a wide range of things. However, it's still not end game, because as we saw, the progression-free survival wasn't that long, and there's a huge bunch of side effects. So I just want to spend, if I may, I think we've got a few minutes left, maybe, just to go over maybe some other directions things can go in. And this takes me back to my university PhD days, but I think it's something that I still hold out hope for, a different way of targeting. my PhD was mainly based on targeting for multiple endocrine neoplasia type 1. You all know what this is, the multiple tumors in the endocrine glands that can occur as a result of mutation in MEN1. So my supervisor, Dr. Raj Thakur, developed a mouse model by knocking out MEN1 in mice, and these mice developed the endocrine tumors, in fact. So here's just a picture of a mouse dissected organs where you can see pancreatic tumors, lipoma, which you get in MEN1. You got to dissect this out on a great microscope, but you can. The parathyroid tumors were present. Pituitary was in the female mice, and adrenal tumors as well. And all these tumors had loss of menin, the protein that is coded by MEN. So in immunohistochemistry, you can see that the tumor areas have complete loss of menin, right? These are heterozygous mice. They had already one allele knocked out, and then as tumors develop, the second one is knocked out, so you have no menin production, okay? So there's no menin in the tumor areas of each of these tumors. And my goal was to develop a gene replacement therapy using MEN1 gene replacement and inject it into the pituitaries of these heterozygous mice and to see if that had any effect on tumor growth. So here's a little picture of what the gene therapy looked like. It's a replication deficient recombinant adenovirus because it's got the E1 and E3 that are related to replication are deleted, and then you've got the adenovirus, present, the rest of it, and then after a CMV promoter, you have your gene of interest, in this case, the MEN1 cDNA inserted here. This took months to just do one picture to show that in mouse embryonic fibroblasts, we actually get loss of menin. We don't have menin in, obviously, when you don't have the MEN1 gene, but you do have it when you've got the MEN treated cells. And then GFP is just green fluorescent protein. You can see viral particles grow fluorescent particles here, and GFP is present on Western blot. So what we did was we injected the pituitary tumors in mice using a transauricular injection because it has a direct view from there into the pituitaries of these mice. This is under MRI, so these mice are kind of under anesthesia. They have pain relief, morphine injections, and we inject them directly into the pituitary tumors through the ear. And you can see that the bolus of fluid is present right at the tumor, and it disappears about 24 hours later. And after 4 weeks of that injection, we called the mice and had a look, and we looked at their pituitaries in the first instance, and we found that those mice that were injected with the gene that incorporated MEN1 had menin expression, whereas it was not present in our controls. And obviously GFP injected mice did have the fluorescence of GFP rather than menin. So this was specific expression in the correct part of the cell, even 4 weeks after treatment. And then we looked at proliferation rates, and this was the biggest finding, was that if we looked at the proliferation rate using BRDU, which is a marker of proliferation, we found that the MEN1 gene therapy treated mice had significantly lower proliferation rates than our controls. And this was 3 to 6-fold, depending on whether we looked at the whole cell, all cells, or just the prolactin expressing cells. And I went on to look at other ways of targeting tumors, and in this case, looking at MEN1 pancreatic specific tumors using something called phage library. And the reason we want to, look at some of these things is because, a lot of these organs are not accessible. Even if you take it to a surgeon, they're hours trying to dissect off other organs that's in front of them. There are major vessels. Some of these tumors are so completely advanced, they're unresectable. and there can be multiple, especially in case of MEN. So really trying to get a systemic therapy that can target tumor cells would be wonderful. You can avoid overexpressing your adenovirus or your protein of interest. You reduce side effects by having delivery only to your target and not elsewhere. So one way I did this was looking at a phage display library, and this was used by one of my co-supervisors who had looked at using this in muscular dystrophy, in fact. And a phage library is looking at a different sort of virus that has a library of peptides on its surface. So these are images of like virus, and then each virus has a different 12, in this case, 12 amino acid sequence on it. And so there are billions, trillions of these going around, 12 to the 10, I think. And we injected these libraries into the tail vein of mice, the MEN1 knockout mice, right? So these had pancreatic tumors. Specifically then looking and collecting those tumors, we would find the phage with specific peptide sequences that bound to our particular tumor of interest, in this case, pancreas. So if we look at only those phage that bound, we could then look at those amino acid sequences, clone those, get the sequences out, and then you regrow these same viruses, amplified in this case, and you keep going round and round in circles. And basically this was a way that I used to find several different peptides that could target our pancreatic tumors in this case. So that's an ongoing story, but it brings me back to why we're doing this. One of my very first cases as an attending was in a 28-year-old woman who had a big thyroid cancer, big lateral lymph node metastases, left side, right side, both sides. Ended up having a long, arduous operation. And even my brother, we both trained in the UK in medicine, and he was like, why are you doing this? It's only going to come back. But it's a major operation. You know, it hasn't come back yet, as far as I know, and this is going back 6 years now. So we can do better than this. We can put our surgeons out of business. So if any of you know of anyone who wants to fund some targeting thyroid cancer studies, please let me know. And in the meantime, here's your code for today's event. I'll just end the slideshow there so that we can look at the people. I think I'm looking at the chat, and it says, by host-driven anti-tumor activity, do you mean natural resident antibody or the antibody that is generated after the tumor is developed? That's a good question. Have you come across any studies using curcumin in thyroid cancer? Not yet. Not yet. I haven't, but if you have, let me know. There's a bunch of different substances being used. In fact, I've heard of this being used in breast cancer. It's a bit easier to study because of the time frames, you know, and the breast cancers can really reduce in size, and that can be measured even over the course of a few weeks, whereas I'm just not sure how to do that for thyroid cancer, you know, especially unless the same person's doing an ultrasound. Unfortunately, ultrasound findings are different from final pathology as well. So where do we see a response? So I'd love to discuss that sort of thing, because I'd love to be able to do some trials here too. But we really need a good endpoint. As far as host-driven anti-tumor activity, I guess I'm mainly referring to natural immune response rather than the antibodies that are generated after tumor is developed, but that's an interesting concept as well. I think mainly it's talking about the idea that your own immune response is responsible to try and curtail tumor growth. So especially T cells, the cytotoxic T cells, you know, they don't just recognize foreign substance. They recognize tumor, it's abnormal, they try and kill those cells. And so the tumor cluster develops by evading that immune response and allows continued proliferation without apoptosis. So that's my understanding. But, of course, there are new, antibodies generated after tumor is developed as well. Between nivolumab and pembrolizumab, which one has better the overall survival? I don't know the answer to that. In thyroid cancer.
Depends on.
I'm hearing the answer is it depends on the tumor. And I think that's probably true. I don't think we've got enough data perhaps to answer that question as well. Can't exactly. Right. I think the combination therapies are going to be more effective than this single arm. And those cases are being used with different combinations on different patients. So I'm not sure we can even compare 1-to-1 right now.
So what is the function of the Does it actually
the function of what, sorry?
SRF.
SRFP2. So it's an angiogenic factor. It just happens to be present. I don't know that we go into to know much about the actual ultimate function, but we found that it seems to be involved in angiogenesis. So I think there's two, in my mind, there's two factors involved. There's angiogenesis and there's just vascular structure. And there are substances that try and target both, right? Because we know that tumor growth is, largely dependent on its nutrients, on oxygen. And so there are specific vascular disruptors. This is more angiogenesis in the new vessel formation. What I think it was found basically as a result of looking at multiple angiogenic factors.
So something in the tumor is driving the expression of this. This is not one driving the world.
That's what we think. Yeah, right. But it's certainly which one comes first, but has been associated. It has higher expression with the more advanced tumors of many solid tumors. Sarcomas, breast cancer, and I mean, in thyroid, we didn't see that advancement because it was high expression in all the stages. But in the others, it's been sort of associated with poor prognosis.
There's something that we can
Can we use it as a molecular marker? I'm hoping that will be an eventual result of this research, potentially. Now, we haven't used so much molecular markers because of the multiple different subtypes and then the clinical utility, like would it matter? And who does it matter? And I think that's where we need to get into the subtypes and then, a personalized molecular profiling, I think eventually will be of use. I think we're not there yet. So I imagine that there's a subtype of patients who have this particular higher expression who would benefit from treatment, let's say. And therefore, yes, it will be one of the markers we could use to see if they, just like PD-L1 expression, how much percentage is there? Would it be useful to use the antibody? And I think in a similar way to that, then angiogenic factors could come out that way, and SFRP2 seems to be a really prominent one. Other questions? Yes, that we just had the response about the fact that nivolumab and pembrolizumab molecules have nearly the same structure, and yes, probably combination therapy will work better. Yeah, thank you. Yes. Oh. No, that was it.
So these days, are we routinely, which I don't see that much anymore. In fact, I don't know if Dr. Mays is also on the chat or the talk, I had to email him to ask about the, search pad. Are they routinely doing the markers, like looking at and then giving us the drivers and all that information on a regular basis? Or are they
I don't think so. I don't think so. And anyone who's out there, we've got our endocrine multidisciplinary conference tomorrow, and we could bring this up with Dr. Mace. I think it's a great question. I don't think we're routinely doing it. I think maybe in the more advanced cases, it might be that we're sending it off. Sometimes we'll be discussing it, let's say, at our tumor board and go, yeah, we should definitely do it for this case. But as far as I can tell, certainly on our pathology reports, we're not getting it. Yeah. Yes. I don't think it's routine.
Easier for me to get it in the meeting. Foundation one and this.
Okay.
My other question is related to, compared to now, to 10 years ago, since the new guidelines came, several years ago, we used to do be over aggressive about radioiodine treatment in the past. And, these days, many of those tumors, we don't send them because it's limited. So with the reclassification, so one of the thoughts I was wondering is how much are we seeing secondary malignancies with radioiodine aggressively used?
So as a result of having given RAI, they're getting secondary malignancies. I don't know. I'm not aware of there being studies saying that we're definitely getting a whole bunch, to be honest with you. Obviously, it was one of the factors that was used to try and reduce it. It's radiation, it's often young people. It's, in my mind, it's probably going to be long-term, long, like 20-year plus follow-up that's going to give us that sort of data, and I'm not sure we have it. I'm not sure that was the main reason we decided to become less aggressive. I think it's a theoretical risk, to be honest. I don't think we have good, solid foundation to say you're going to get a secondary malignancy, especially, yes, it's systemic, but, the doses we were giving, not that high. I think people were getting some side effects. I think really main thing, it's a hassle, it's a cost. You're potentially giving them Thyroid or taking them off. We used to withdraw everybody. That was a hassle. 4 weeks without thyroid hormone. But it's, also the side effects, the dry mouth, everything. Just people feel different, the salivary gland. I honestly think it's because we've become more and more minimally invasive, because, those side effects don't sound horrendous. I guess if you have them, they probably are. And a lot of people do complain. But I guess if you've got what sounds like a completely indolent cancer, you don't want to be giving it. Having said that, I should plug that somebody came to my clinic the other day and was just surprised that thyroid cancer could have other kind of outcomes. And he'd just been called, I think, by a nurse and told, oh, yeah, you have thyroid cancer. Don't worry about it. It's not going to affect you. And they'll just take the nodule out. Technically, I don't know what was said, but it's like, well, no, we have to take the whole thyroid out. That, there are injuries that could happen. And it was like a total shocker, So I think we're more and more getting used to it's an in and out. Let's just get it. If you don't need RAI, then you don't need it. I think that's just the way we've been going. Yeah. If anybody wants to come and see it, feel free. You're welcome to my OR.
Yeah, we were actually talking about that.
Yeah, sure.
One question. With the treatment of
it's a tough question because these patients with anaplastic thyroid cancer don't survive very long as is, right? They, if 6 months, if 6 months you get there, you're probably like, okay, that's about it. And I think it would be really hard to do a neoadjuvant treatment for those patients because they just grow so fast. unless it was a miracle drug and it really shrunk, I just don't see even a trial of that going on, because if it's at all resectable, it's barely resectable. So, unless we can find something that just, in an unresectable situation, right, then you're not considering surgery, then you give it, and then you go, oh, wow, now it's become resectable. Great. That's, I think, the situation where we'd use that and be able to tell. I don't think we'd use it if we at all think possible that it might be resectable, because there's a very narrow window and it's already growing and it's already going to invade and they're going to asphyxiate and it's not pleasant. So we're trying to avoid a tracheostomy in the first place. So I think that it's possible that we could do trials in the unresectable patients, or even someone with metastatic disease. At the end of the day, those patients are still going to have local symptoms and, they're technically unresectable. So we should give it in those patients and then see what effect it has. And then we can go on and maybe look at if it improves survival. I don't think anything's improved survival in anaplastic thyroid cancer is the bottom line.
Yeah, I think some of them are statistical, but not
right. I mean, it's amazing. It's a breakthrough. We're going to get there eventually, that, wow, something had an effect on this horrible tumor. But, they're just so aggressive, so recurrent, that we haven't found anything that affects survival in them at all. I mean, imagine we're giving them chemo, we're killing the cells, we're giving radiation, it still comes back. Still comes back, sometimes within 4 weeks. It's pretty bad. Yeah. So that's why we need targeting. All right. Sorry to run over time.